we covered most of the issues already in our previous discussion. So the main question is what is the difference in our approach of patients who are treated outside clinical trials? In principle, these are the majority of patients, MDS patients all over the world. And the question is, so should we follow the up-to-date guidelines? Which guidelines? Are we able to treat the patients with new drugs which are not incorporated in the current guidelines because of the recent introduction? So, for instance, EMA and FDA approved drugs. Can we already incorporate them in our daily practice? So we're talking about high-risk MDS. So we can disregard the issue of luspatercept and related drugs for anemic low-risk MDS patients. We discussed already which patients should be candidates for stem cell transplantation. So that's usually not, this is according to the guidelines, and we discussed the selection of the patient in our previous topic. So my question to the participants is, so do you think that the guidelines, the current guidelines published by the ELN and by and updated guidelines by within the MDS Right and the national guidelines, are they sufficient to guide the clinicians to the proper interventions in high-risk MDS? So that's my question. The general approach in high-risk MDS in patients who are not candidates for transplantation are hypomethylating agents, sometimes with additions, but up until now, maybe apart from venetoclax, we don't have any approved drugs, at least in Europe. So what's your opinion about this?
So, I mean, in Toronto, in Canada, we have access to hypomethylating agents. Azacitadine is funded for higher risk MDS. Mm-hmm. In Ontario, they're still using the IPSS definition of intermediate 2 and high. And so up until now, if I had a patient who is higher risk by the IPSS-R, but not by the IPSS, I was able to, I can obtain the azacitadine compassionately from the generic company. Sort of that's been our algorithm. And then about a year ago, we had available to us through a patient support program, because it's approved but not yet reimbursed, to use oral decitabine, Aztec 727. Mm-hmm. And so I guess the tension, and I'm always asked, which do I prefer? Of course, it's more convenient for the patients to receive Aztec 727, but are they interchangeable drugs? And we don't really know that. I mean, we have registry data that would suggest the survivals are similar, but many of the patients in the registries that have been evaluated in the US include lower risk MDS patients. And so it's hard to know. It's never sort of been restricted to just higher risk MDS to sort of see that the survival curves are interchangeable. I think there was one paper that suggested those with excess blasts, more than 5% or higher, when you compare the survival curves of those receiving AZA versus decitabine, are superimposable. But again, that probably includes some patients that would not, fall into higher risk categories. So it's my impression, having used a bunch of Aztec 727, is that it is more cytotoxic and more myelosuppressive. And And so my algorithm for treating these patients has been, and it's sort of a more effective debulking agent in patients with very excess blasts. So my approach has been, right or wrong, if I have a younger patient who I'm trying to get to allo transplant, and I have available to me Aztec 727, I might choose that over AZA because it seems to work a little bit faster, at least maybe not in achieving hematologic improvement, but in debulking the disease. So I can get them to transplant before 6 cycles, where you may not see such a fast response with azacitadine. I haven't used a lot of—
for the majority of patients who are not candidates for transplantation.
Yes, correct. So in those that are not candidates for transplant, I have primarily been using azacitidine in those patients. I have not combined it with venetoclax, off-label venetoclax, because I'm still waiting for the Verona study to come out, or the results to emerge. Of course, it's enrolling right now, because we've been disappointed many times by lots of phase 1-2 studies that in phase 3 don't end up, bearing fruit. Yeah. So I haven't been using a lot of venetoclax, other than maybe in a scenario for those where I'm thinking of allo transplant, to try to rapidly decrease their blast burden.
So in general, you advise to use the classical hypomethylating agents and wait for the phase 3 outcome data. Maybe the exception for patients who are candidates for transplantation.
In Japan, oral decitabine is not yet approved, but fortunately, azacitidine can be used so-called high risk. So we can use IPSS or IPSSR or whatever risk scoring system to evaluate patient as high risk. Then azacitidine is covered by the insurance. So our choices for a drug treatment is only old azacitidine, that's alone. And we usually follow Japanese guideline published by Japanese Society of Hematology. But the general scheme is, of course, the same as ELN or MDS right guidelines. So only difference is the approved drug.
Okay, so the situation is more or less similar all over the world, at least for high-risk MDS patients. It's unfortunately still a very simple approach. The main question is the patient transplantable, yes or no? And that, of course, we discussed in our previous topic extensively, so I don't think we should repeat the discussion right now here. In the Netherlands, if you want to have, let's say, alternative treatment, alternative to the regular hypomethylating agent treatment, the patient should be referred to an academic center treating MDS patients. Then, of course, the patient can be entered in a clinical trial or in a program, a study program. But that's not the question for today.